Hi everyone, so I'm Peace and you obviously know Dr. Gordon, who's our resident celebrity. So in this video, we're going to be speaking about the clinical presentation of a patient who is a survivor of IPV. I think it's a very, very important conversation to have because one, we as clinicians need to know when it's important to ask. We need to know the signs we should look for. And we should also sort of prepare ourselves to be ready for our patients when they need us. So Dr. Gordon, in your extensive experience, I'm sure you know that one of the ways, like I think for me personally anyway, when I think about an IPV survivor, you always think about the physical. How often or how common is it for a patient to present with physical signs of IPV?
Thanks, Peace. And that is ultimately the crux of the conversation, because only about 9% of victims will present with physical evidence or with a physical reason like an injury for IPV. And what people need to understand is that IPV is actually by far more predominantly a psychological crime. So physical, like injuries presentation is in fact the minimum.
Yeah, sure. So then what do we see when a patient walks into the room? I mean, like you mentioned that it's predominantly a psychological crime. I've seen it in slides and I've heard you mention that gut feeling, but what alerts your gut that something's not right?
Okay, so firstly, it's important to understand that somebody who's a victim of IPV could be identified in literally any clinical discipline because it cuts across so many different means of presentation. So things that would alert me in a consultation to ask someone about IPV are, I think, predominantly about the body language of that person that I'm speaking to. Because people who, when you go to the doctor, people can't wait to tell you their whole story and the whole history and everything that goes with it. But if someone is very demure, very sort of closed off, not making eye contact, not answering questions that you're asking, that's not normal behavior. And I would want to know about what underlies that. Someone who's incredibly anxious or tearful or looking very depressed, flat affect, those kinds of things would make me ask about home circumstances, of which one is obviously the nature of the relationship. And then another big red flag is if there is a partner in the room who is dominating the conversation, answering everything on behalf of the woman. It's normally a male and a female. And not giving her a chance to speak, or they're trying to make all the decisions. That is a big, big red flag warning signal for me. So those are in terms of the kind of behavioral aspects of the person who's sitting in front of you. And it's often that behavioral aspect that gives you that gut feeling that something isn't right. And you've interpreted on a subliminal sort of a level. But in terms of kind of presenting complaints that people might come in with, common things would include, so going back to the fact that this is predominantly a psychological crime, if you are being psychologically terrorized every single day of your life, you are highly likely to have some kind of psychological reaction to that. So depression, anxiety, PTSD, suicidality, substance abuse, those would be very high on the list of ways into which victims could get into the system. Then we have more sort of vague things like chronic pain syndromes that you can't find an organic cause for, or just vague things, or repeated visits in and out of the clinic, but you don't ever find anything concrete. That would make me want to ask. In terms of obs and gynae presentations, we know that women who are pregnant are at a higher risk of IPV. And the mechanism for that is if you have a very jealous partner and the mother's attention now starts focusing on the fetus, that jealousy turns into a jealous rage, and they can attack the pregnancy. So, you know, pregnant women are at a higher risk. Issues around things like recurrent STIs. I would want to know what is the dynamic in that relationship, or things like recurrent TOPs as well. If somebody comes in for one TOP, that's quite common. You might not think about going there, or if they come in with one STI, okay, everyone can get an STI. But it's a pattern of recurrent issues over time that would make me worry. And then obviously there are physical injuries, and those you're going to ask in the context of a physical injury when there's a recurrent nature again. So somebody's got a casualty folder who's that thick and it's an injury every time, or when the person's explanation of how they sustained that injury actually doesn't make medical sense to you. I would ask in those circumstances. And then finally, a very, very important thing to trigger this thought is child abuse. So if you are working in a peds casualty, or in peds one day, you're all going to rotate through peds, and you feel like a child is being abused, your next question is going to be what's happening to the mother, because we know that about 50% of perpetrators will abuse the children as well. Of course, it could be the mother who's abusing the child, but there's a thought that you have to have, because family violence is often family violence. So those are the kinds of things that would make me want to ask. Ideally, we should be asking everyone, but realistically, we don't have time for that.
Yeah. I think you make such an important point about the fact that it's not just like you often try to compartmentalize things as, okay, I'm learning about IPV in gynae. It is something that I apply when I'm in a gynae OPD or I'm seeing gynae patients. But the fact that it transcends various clinical disciplines, various clinical settings, and it should always be something that's in the back of our mind. We could be sitting in front of a patient in a neuro OPD who's come in with recurrent headaches, and we should be asking, like you said, peds, we have a child, and we should be asking.
What you're saying is true. I mean, the one thing that I forgot to mention in terms of clinical presentations, which is very subtle, is that just about any chronic condition that you can think of is likely to be worse off in a victim of IPV. So hypertension, diabetes, HIV, and there's a lot of reasons for that. So you're living in absolute terror all the time. Are you going to remember to take your medication? Do you even want to? Do you want to be alive? Do you have access to the clinic? Does your partner allow you to go and get the services that you need? So you could be a GP with someone whose BP is just uncontrolled, or their sugars are uncontrolled, or like you say, chronic headaches. That is something that you really need to think about, because it is so prevalent.
Yeah, I mean, like that raises things like poor compliance, missed appointments. I think often a patient is always missing the appointments when they're in front of you. They look like they really want to be there, and you sort of berate them without understanding that there's so much lying underneath the surface. I think, sure. And that's not even it's not a clinical thing. You mean like someone who's always late for appointments or never comes or missed this. You don't think about it as possibly a symptom and a red flag for us as clinicians. Sure.
Yeah.
Thank you, Dr. Gordon. So just to summarize, 9% or only 9% of most of IPV cases present with physical symptoms such as like bruises and broken bones. And the other 91% is more subtle. It can be chronic conditions, from mental health conditions to chronic pain syndromes, or like you mentioned, poor compliance or poorly treated chronic conditions. Look at children. Abused children often point to an abused mother. Look at the partner. How's the partner behaving? Is the partner controlling or dominating the conversation? And then also look at the patient's body language and how forthcoming they are, and if you are getting a sense of anxiety for them. And remember, it's important to have a high index of suspicion, but like Dr. Gordon just said, we won't pick up every case, but it's important to pick up when and what you can. Thank you, everyone, and thank you, Dr. Gordon.
Thank you, Peace.